Hello, my name is Andrew Krahn, and I'm Second Vice President at Heart Rhythm Society and have the privilege of being the Abstract Chair for the FHRS 2020 Science. This is our first of 4 late-breaking clinical trial sessions entitled Randomized Clinical Trial. This is going to be an outstanding session where we hear from 5 different investigators who led clinical trials looking at innovative science in the realm of randomized trials. Evidence-based medicine would suggest the highest form of evidence is generated from comparative trials that use randomization, and that's the case in this particular instance. We have exciting developments in the area of ambulatory or medical management for termination of supraventricular tachycardia. Finally, input into the merits of established platform of subcutaneous ICD and its comparison to transvenous ICDs. The use of smartphones as a way to improve our atrial fibrillation care. The incremental value of a combined team approach to atrial fibrillation looking at the converged technology using epicardial surgical techniques along with transvenous endocardial techniques. And finally, using contact force as a way to establish the efficacy in a multicenter study of ablation for persistent atrial fibrillation. I think this whole breadth of topics as well as comparative evidence is really going to be very informative to our clinical practices. It sets the stage for us to evolve our guidelines, inform care, and apply many of these lessons to our immediate practice. I look forward to spending the next hour with you and draw your attention to the anticipated discourse that will happen on HRS 365. And welcome your thoughts and insights into the utilization of these data as it evolves our practice. I hope you enjoy the session and look forward to connecting after you have reviewed the content.
Thank you. On behalf of my co-authors, co-investigators, the study coordinators, the sponsor, and most importantly, the participating patients, it is my pleasure to present the primary results of the Node 301 trial. Relevant disclosures are shown here. Etripamil is a novel L-type calcium channel blocker. It is formulated and administered as a nasal spray. Etripamil is being developed as a self-administered therapy to terminate AV nodal-dependent PSVT outside of the emergency room or hospital. Etripamil nasal spray has a rapid onset of action and is short-acting. Like other L-type calcium channel blockers, etripamil slows AV nodal conduction. As shown on this slide, after the nasal spray, PRR interval prolongation occurs rapidly with peak effects within 5 to 10 minutes, followed by a decline in effects over the next 30 to 40 minutes. The Node 1 Phase 2 dose ranging study demonstrated that etripamil was highly effective in converting PSVT that was induced in the EP laboratory. The 70 milligram dose had the best balance of efficacy and safety, and therefore this dose was used in subsequent Phase 3 studies outside the hospital environment. Today I present the primary results of the Node 301 study, which was a multi-center randomized double-blinded placebo-controlled efficacy and safety study of etripamil nasal spray 70 milligrams for termination of spontaneous episodes of PSVT. The study recruited adults with an ECG documented history of sustained PSVT with episodes lasting at least 20 minutes. The study was conducted at 77 sites in the US and Canada. Key exclusion criteria are shown on this slide. All subjects were trained in proper use of the nasal spray and then self-administered an etripamil test dose while in sinus rhythm with their ECG and vital signs monitored for 30 minutes. Failure of the test dose occurred if any of the criteria shown on this slide were seen. The Node 301 study design is illustrated here. Subjects with a history of PSVT who passed the test dose were randomized to etripamil or placebo in a blinded 2-to-1 ratio. Subjects self-administered the nasal spray outside the hospital for a suspected episode of PSVT. The study was event-driven. A pre-specified analysis was planned after more than 150 positively adjudicated PSVT episodes were treated with study drug. 518 subjects were screened between July 2018 and January 2020. 431 received the Etripamil test dose, and only 10 subjects, 2.3%, failed the test dose. Therefore, 419 subjects were randomized to study drug. After a median of 39 days, 198 subjects experienced symptoms perceived as due to PSVT and that did not terminate with a vagal maneuver. These 198 subjects recorded their ECG for 5 hours with an event monitor and self-administered study drug. 156 subjects, 79%, had a PSVT episode that was positively adjudicated by an ECG events committee. 107 episodes were treated with Etripamil and 49 with placebo. The demographics of the study populations are shown here. The median age was about 55 years. The youngest patient was 18 and oldest 90 years. As expected, twice as many subjects were female than male. Subjects had a high burden and frequency of PSVT episodes in the past year, as well as emergency department visits over their lifetime. The primary study results are shown here, displayed as a Kaplan-Meier plot of percent of patients converting to sinus rhythm versus time to conversion over 5 hours. The Etripamil and placebo curves were not statistically different, p equal 0.12. Therefore, the Knops 301 trial failed to meet its primary efficacy endpoint of superiority over 5 hours. Notably, early during the first portion of the curves, treatment favors Etripamil over placebo. Therefore, and based on the drug's known pharmacology, a post hoc analysis was performed and demonstrated that Etripamil was significantly more effective than placebo in converting PSVT over the first 45 minutes, p equals 0.02. The curves separate early within the first 5 minutes, favoring Etripamil, and remained separated by about 15 to 20% absolute difference in efficacy. Returning again to the 5-hour Kaplan-Meier curves, the placebo blue curve crosses the Etripamil red curve at about 100 minutes. Beyond this time, there are few or no placebo patients remaining to resolve their events. Censoring is indicated by the tick marks on the curves. Censoring occurred in most cases at a time point when patients went to the emergency room and received adenosine or other rescue medical therapy. Censoring strongly influenced the shapes of the Kaplan-Meier curves, especially in the placebo group. Etripamil was well tolerated and safe. The most common adverse events were nasal discomfort and congestion that typically were transient in nature and mild in severity. There were 2 cases of first-degree AV block in the Etripamil group and no cases of higher degrees of AV block. There was 1 case of non-sustained VT in each of the Etripamil and placebo groups that occurred after termination of PSVT. There were no reports of syncope. In summary, Etripamil nasal spray, 70 milligram dose, did not meet the Knops 301 primary endpoint of conversion of PSVT over 5 hours. During the first 45 minutes, Etripamil had a clinically meaningful treatment effect consistent with the drug's pharmacology. Etripamil had an acceptable safety profile when self-administered by patients during PSVT in a medically unsupervised setting. Thank you.
It is my pleasure to participate in this session. My first commentary is on the Knops 301 trial. But before I delve into that, I wanted to share some disclosures. One relevant relationship is that I receive consulting fees from Milestone Pharmaceuticals, the sponsor of the Knops 301 trial. As many of us know, there is indeed a clinical need for a medication that can be self-administered at home by patients to terminate SVT and avoid the need to go to the ED. While the Node 301 trial did not meet its primary efficacy endpoint, several findings are noteworthy. Patients enrolled in the trial had a high burden of SVT at baseline. So I'm really curious how patients with less burdensome SVT would do on this medication. Of course, this was not investigated in this trial. The investigators used a time frame for conversion of 5 hours. Given how short-acting Etripamil is, a shorter time frame would have been more informative. The safety data in the trial are actually reassuring, but it is important to keep in mind that patients had to be selected for enrollment on the basis of passing a testing dose of this medication in sinus rhythm. And it is indeed interesting that patients in the placebo arm were more likely to go to the ED to get a rescue treatment. While there may be several reasons for this, it is important to highlight that in this figure that the investigators shared with us, we have to be very careful and cautious how we interpret the findings after 120 minutes, because at 120 minutes, only 5 patients were left in the placebo arm for analysis, and at 150 minutes, only 1 patient was left in the placebo arm. Importantly, only 15% of people screened for enrollment in the trial failed. That tells me that the majority of patients with SVT will likely tolerate this medication. I want to congratulate the investigators for the completion of this trial, and I'm really looking forward to learning more once their trial gets published. Thank you.
This is Eric Prystowsky, and I'm commenting on the Etripamil study by Dr. Stambler and colleagues. I have the hawk position, and as everyone knows, the hawk is the bird of prey. So my position is to feed off of this study a bit. So let's talk about the study. The study design is akin to what would have been considered in the past like a pill in the pocket for breaking atrial fibrillation. I'm going to call this puff in the pocket because this is a nasal puff of this drug, Etripamil, to try and terminate PSVT. There's too much to discuss in a short period of time, but let me just say that these patients are supposedly AV node dependent, yet there was never an electrophysiology study, so we really don't know the diagnosis of the patients. And the drug, it's an interesting concept, supposedly has its maximum effect in somewhere close to 10 to 15 minutes. Yet in this actual study, very few people terminated within 10 to 15 minutes. And in fact, the study results were negative. And then the authors did what a lot of authors do. They dug down into it and said, well, what else is there? And I think that's reasonable. And they found out actually, if you take a 45-minute time frame, then more people responded to drug than placebo. But it's still, in my opinion, not clinically useful. Because if you think about the patient, they're going to have to go lie down somewhere for what, an hour until the drug works. And also, I'm surprised the authors didn't ask them to repeat vagal maneuvers after the drug was given, because that often works. And if you try to do this standing up, autonomics work against you. So what's the bottom line? It didn't really work. I'm not a great fan anyway of these pill in the pocket and now, for example, puff in the pocket. One of my favorite fairy tales is Puff the Magic Dragon. And Puff in the Pocket is sort of like Puff the Magic Dragon. A wonderful story, but not based in reality. And my final comment is these patients should have undergone ablation. This is an arrhythmia in any good lab, a 95+% success rate with 1 ablation with minimal complications. And this is not where one should be trying to develop drugs to take care of these patients. Ablation works great here. Thank you.
Good morning. These are my disclosures. First of all, I'd like to thank the FHRS for creating this online forum for us to present our data. And now, on behalf of the PRAETORIAN investigators, I'd like to present the investigator-initiated PRAETORIAN trial with the title, A Prospective Randomized Comparison of Subcutaneous and Transvenous ICD Therapy. The background of this study is that transvenous ICDs are effective but come with major limitations, especially that in 10 to 20% of the patients there's a lead failure after 6 years of follow-up. For that reason, subcutaneous ICDs were developed to overcome these lead-related complications. Currently, we only have registry data on these SICDs, and these studies were mostly done in young patients with relative preserved ejection fractions. They've shown a high shock efficacy, they've shown less ICD-related complications, but they've also shown more inappropriate shocks. Currently, no randomized controlled trials are available that compare these two therapies. So therefore, we designed the PRAETORIAN trial with the main hypothesis that in a typical ICD population, the SICD is non-inferior to the transvenous ICD with respect to major ICD-related adverse events, being inappropriate shocks, ICD-related complications that require intervention with a special focus on lead-related complications. If we then look at the methods of our trial, you can see our inclusion criteria: patients over the age of 18 with a class 1 or 2A indication for ICD therapy for primary or secondary prevention according to current guidelines. Major exclusion criteria were indication for pacing therapy, being Brady, CRT, and ATP. Another major exclusion criteria was failed SICD vector screening. When you then look at the figure, you can see the flow chart of this trial, and you can see that between 2011 and 2017, 849 patients were one-to-one randomized, where 426 patients ended up in the SICD arm and 423 patients ended up in the transvenous ICD arm. This was performed in 39 centers in the EU and the US, and we then followed our patients for a median follow-up of 48 months, for the primary endpoint being complications and inappropriate shocks. And since inappropriate shocks are part of the primary endpoint of this study, we mandated standardized ICD programming with major components of that being delayed therapy and high rate cutoff. If you then look at the baseline characteristics of our study, you can see that we achieved our goal of investigating how the SICD operates in a traditional ICD population. Our median age in our population was 63. More than 90% of patients had an ischemic or a non-ischemic cardiomyopathy. About 20% of patients had a secondary prevention indication, and the median ejection fraction was 30%. And now for the main results of our study. At 4 years, you can see that the primary composite endpoint of inappropriate shocks and complications occurred in the transvenous ICD arm in 15.7% of the patients. And I think that the big news of this study is that in the SICD arm, there was no difference with, at 4 years, the occurrence of the primary endpoint of 15.1% in the SICD. And this means that the SICD is non-inferior to the transvenous ICD with regard to this primary endpoint with a p-value of 0.01. And if we then look at the individual components of the primary endpoint, we do see a difference, and especially a difference in trend. When we look at the inappropriate shock rate, you can see that in the SICD this was 9.7% and 7.3% in the transvenous ICD arm. There's a trend towards a difference, but this was not significant with a p-value of 0.14. If we then look at the device-related complications, we also see a trend, but then the other way around. So there are less SICD-related complications, 5.9% versus 9.8%. This difference was also not significant. When we then look at the numbers associated with these figures, you can see that the primary composite endpoint occurred in 68 patients in both arms, and that when we look at the individual component of inappropriate shock, that occurred at 41 versus 29 in both of the arms. I think it's important to mention that the main driver for inappropriate shocks in the transvenous ICD arm was AFib and SVT, and the main driver for inappropriate shocks in the SICD arm was cardiac oversensing. When we then look at the device-related complications, we also see a difference, 31 versus 44 in the transvenous ICD arm. There were more infections in the transvenous ICD arm, but this was counterbalanced by more bleedings in the SICD arm. The major difference in numbers between the complications was caused by lead-related complications, as you can see over here. And you can see that even better when we portray that in a figure. As you can see over here, 1.4% lead-related complications for the SICD versus 6.6% in the transvenous ICD. And this was highly significant. Obviously, it's important in any ICD trial for efficacy and safety to look at mortality. And you can see that there was no significant difference in mortality in the trial, with a special focus I want to make that the sudden cardiac death rate in both arms was exactly the same, 18 versus 18. The only difference in numbers between mortality were mostly driven by non-cardiovascular death, 31 versus 22. Therefore, I'd like to conclude that in a conventional primary and secondary prevention ICD population, SICD is non-inferior to the transvenous ICD with respect to major ICD-related adverse events. There's no difference in ICD complication rates, although there was a trend towards more shock in the SICD arm. There was no difference in inappropriate shock rate, although there was a trend towards more shocks in the SICD arm. And I need to mention that the ICD complication trend was in favor of the SICD. Especially less lead-related complications with the SICD, 1.4 versus 6.6%. Therefore, we conclude that the SICD should be considered in all patients in need of an ICD without a pacing indication. Thank you, and I especially want to thank all the persons that were involved in this trial in all the Praetorian sites, but also the trial office. I'd like to mention that the data will soon be published in one of the major scientific journals, and I also would like to mention that we extended the follow-up of the Praetorian trial with another 4 years. Thank you very much. With regards to the publication I just mentioned, I'm happy to be able to share with you that the full dataset of the Praetorian trial is in press at the New England Journal of Medicine. Unfortunately, due to the corona pandemic, the publication date is still unclear.
Thank you for the opportunity to comment on the Praetorian trial. I'd like to start by congratulating the investigators on the completion of this important trial. It is indeed great to finally have a randomized clinical trial comparing the SICD with the transvenous ICD. As you heard from Dr. Knops, the SICD was found to be non-inferior to the transvenous ICD in its effect on the primary endpoint of inappropriate ICD shocks and complications. Numerically, there were fewer complications with the SICD, but these were counterbalanced by a higher number of inappropriate shocks in the SICD arm. However, it is important to keep in mind that the trial was not powered to look at these two endpoints separately. I was curious to see the numbers related to non-cardiovascular death, which appeared to be higher in the SICD arm. It's possible that this may be due to a higher rate of comorbidity in the SICD arm, as we were not able to see those data. But based on the baseline characteristics that the authors shared with us, it appears that the randomization worked in that trial. So I doubt that the comorbidities were not evenly distributed between the two arms. And I would love to hear from the investigators their thoughts about this finding. As we all know, the SICD has evolved, and with this evolution, the newer devices are better able to discriminate VT from other potential causes of shocks. I doubt that the investigators have adequate numbers, but if they do, it would be great to examine the rate of inappropriate shocks by device model. So what are the clinical implications of the Praetorian trial in the majority of patients with ICD indications who don't need to pace and who pass the screening test? The option of an SICD versus a transvenous ICD should be presented to the patient. However, I personally would not extrapolate the results of the Praetorian trial to every patient we see in clinical practice. And I'm really intrigued by the role of the SICD in patients with HCM who are known to be at a higher risk of inappropriate shocks. It would also be really great to see if these results can be replicated by other groups. We know of at least one other randomized clinical trial comparing these two types of ICDs. And I'm really excited to hear that the investigators have extended follow-up in this trial by 4 years. Again, congratulations to the team.
This is Eric Prystowsky, and I'm speaking as the hawk, the bird of prey, on this study by Dr. Knops and Associates, the PRAETORIAN study, which basically looks at a comparison of subcutaneous ICD with the transvenous ICD. And the study was well designed, and they did meet their goal, which was non-inferiority. So you have to look at more detail and say, what does this all mean, and what do I do with these data? So there were too few people, in my opinion, in secondary prevention group for me to make any comment at all. I think there were only 19% of the total study population. So I do not think these data apply there. And I also am concerned about there are too few hypertrophic myopathy patients, and they can be a problem with sensing with a subcutaneous device. So I'd be a little careful looking there. There was an equal number of lead problems or basically complications. So the two were comparable. They had different, as we all know from previous studies, they have a little different mix there. The thing I was a little disturbed by was there was a 6% of inappropriate shocks in the transvenous lead group. And there are lots of ways to avoid inappropriate shocks. And I think 6% is way too high in the modern era. So I was a little disturbed to see that and not quite sure why that happened. So in the end, what do these data mean? Let's say they're equal as far as problems are concerned. Then you have to decide which patient will you select. So, okay, I think that's fair for primary prevention, but there are two other things you must consider. First of all, you should definitely consider the cost. Now, maybe it's different in Europe, but in the United States, the subcutaneous ICD is significantly more expensive. Second of all is the battery life. We really don't know the comparison there, but in some of the transvenous ICDs, now the battery life is quite long and certainly is going to outlast the subcutaneous ICD. So what is my conclusion? I think the study result was sort of anticipated in my opinion. I wasn't surprised by it. They have different complications, but they sort of come out in the wash. I think it boils down to a primary prevention patient who doesn't need pacing, who you don't think is going to need CRT, and who you feel that maybe it's okay to go ahead and use it, and you're not worried about the money or the longevity, I'd say take your pick.
Good morning. My name is David DeLurgio from Emory University in Atlanta. I would like to thank the organizers at HRS for making this virtual presentation possible. I will be presenting the Converge randomized controlled clinical trial data. These are my disclosures. AF affects more than 33 million people worldwide, with approximately 70% of AF patients having non-paroxysmal AF. Effectiveness of endocardial catheter ablation for persistent and long-standing persistent AF is limited due to progressive electrical and structural remodeling, but best practices for substrate modification are as yet undefined. This is demonstrated by the STAR-AF2 trial, which showed only 41% freedom from AF with PVI alone in persistent AFib ablation and no benefit from further substrate modification. The conversion procedure combines minimally invasive surgical epicardial endocardial catheter ablation to achieve a more comprehensive ablation strategy. The convergent procedure combines minimally invasive surgical epicardial and endocardial catheter ablation to achieve a more comprehensive ablation strategy. The Converge trial was designed to compare the effectiveness of combined epicardial posterior wall ablation, shown in blue, and endocardial catheter ablation, shown in red, to standard endocardial catheter ablation for the treatment of persistent and long-standing persistent AF. The Converge trial is a multi-center open-label randomized controlled longitudinal pivotal study. 153 patients were randomized in a 2-to-1 fashion to either the hybrid convergent ablation procedure or to endocardial ablation only. The follow-up schema is shown in the slide and is standard. Key inclusion and exclusion criteria are shown. There was no limit on duration of AF, and LA size up to 6 centimeters was allowed. In the convergent arm, the epicardial lesions are created endoscopically using the Episense ablation system within the pericardial space. The pericardial space was accessed using either transdiaphragmatic or subxiphoid access without any chest incisions. The pericardial reflections were not dissected. These are the lesion sets utilized in the CONVERGE study. The hybrid procedure is a combination of epicardial posterior left atrial wall ablation with endocardial ablation shown here. And on the right, we have the standard ablation using endocardial ablation only, achieving pulmonary vein isolation with a roof line and a cavo-tricuspid isthmus line. We hypothesize that the convergent hybrid AF ablation procedure is superior to endocardial catheter ablation alone for the treatment of persistent AF. The primary effectiveness endpoint was assigned as freedom from atrial fibrillation, atrial tachycardia, or atrial flutter, absent a class 1 or 3 antiarrhythmic drug, except for a previously failed or intolerant antiarrhythmic drug with no increase in dosage. We sought to demonstrate that the risk of the convergent procedure was acceptable. It was estimated that the incidence of primary safety events would be less than 12%. The primary safety endpoint was the incidence of major adverse events shown here. The mean duration since diagnosis of persistent AFib was 4.5 years. Over 40% of patients had long-standing persistent AFib. There were no differences between the two arms with the exception of an excess of men in the study group. Total ablation time was similar in the two groups since less endocardial ablation was required after epicardial ablation. Initial procedure involved transdiaphragmatic access to the pericardium. Later, a subxiphoid option was added. These figures are left atrial electroanatomic voltage maps obtained during the endocardial portion of the procedure. You can see the epicardial lesions as a gray area and surrounding voltage attenuation after the epicardial ablation, but before endocardial ablation. On the right, after completion of the procedure, we see complete electrical silencing of the posterior wall and the pulmonary veins. This Kaplan-Meier curve shows our primary effectiveness endpoint. The primary effectiveness hypothesis to demonstrate a superior success rate of the hybrid conversion group over the endocardial catheter ablation group was achieved. Of all evaluable patients at 12 months, the primary effective endpoint was achieved in 67.7% of subjects in the convergent hybrid ablation arm, compared to 50% of subjects in the endocardial ablation only group. The observed success rate difference of 17.7% favors the hybrid convergent group with a p-value of 0.0253. This slide shows, in addition to the primary effectiveness endpoint, the secondary effectiveness endpoint of a greater than 90% burden reduction of AFib, which was achieved in 80% of patients in the convergent arm versus 57% of patients in the catheter-only arm, and other secondary endpoint of freedom from atrial fibrillation alone at 12 months, which was achieved in 71% of patients in the convergent arm and 51% of patients in the catheter-only arm. The primary safety endpoint was the incidence of major adverse events for patients undergoing the hybrid convergent procedure through 30 days post-procedure. The MAE rate of 7.8% was lower than the protocol-specified performance goal of 12%. There were no atrioesophageal fistula, no cardiac perforations, or deaths. The 4 pericardial effusions are thought to be inflammatory in nature, and of note, 3 of these 4 patients were not on an anti-inflammatory regimen. In conclusion, this is the first multicenter randomized controlled clinical trial comparing the effectiveness of combined epicardial and endocardial ablation to endocardial ablation alone for the treatment of persistent and long-standing persistent AFib patients. The study demonstrates that the hybrid convergent procedure has an acceptable safety profile and superior effectiveness when compared to endocardial catheter ablation alone for the treatment of persistent AFib. The study also provides high-quality evidence supporting the addition of transmural posterior wall ablation to pulmonary vein isolation. And lastly, the study emphasizes the value of a team-based approach, where collaboration between the electrophysiologists and cardiac surgeons helps achieve improved outcomes for patients with persistent AFib. I would like to thank my co-investigators in this trial. Thank you very much.
Really exciting and interesting results that were presented by the CONVERGE randomized clinical trial investigators. Those results, I think, should make patients with persistent and long-standing persistent AFib feel more hopeful. As many of us know, studies have shown that pulmonary vein isolation has better outcomes in patients with paroxysmal than patients with persistent atrial fibrillation. So it was really good to see the results of the Converge randomized clinical trial that only included patients with persistent and long-standing persistent AFib, and the number of patients with long-standing persistent AFib was non-trivial. They had 65 patients, accounting for 42% of the patient population. The efficacy results with the hybrid endocardial epicardial approach were really encouraging and certainly corroborate the long-held opinion that patients with persistent and long-standing persistent AFib may need a different approach to ablation than patients with paroxysmal AFib. The hybrid procedure also had a reasonable safety profile, but it is really important to keep in mind that experienced operators perform the procedure and less experienced operators will likely have more complications. The preponderance of men in the trial was noticeable. And we really know that women in general have a higher risk of complications from AFib ablation, other invasive EP procedures. And so I'm really eager to see more data in the future on the safety of this procedure in women. Another noteworthy feature is the mean left atrial diameter of 4.4 centimeters, with patients with a larger left atrium benefit. And if so, would they be expected to benefit to the same extent? I'm really excited about these results and greatly look forward to learning more about this procedure. Congratulations to the team.
This is Eric Prystowsky. I'm doing the Hawk commentary on the trial by Dr. DeLurgio and colleagues using the convergent hybrid approach to persistent atrial fibrillation ablation versus an endocardial approach only. Actually, I know a fair amount about the convergent approach because we were early investigators with it, and actually it does work, and we used it for a while. We're just not involved with that anymore. However, the study did compare these two approaches, and I think what you have to understand is a comparison. It was literally apples and oranges, because in the endocardial approach, it was nothing more than PVI, which is not inappropriate, but you're comparing that to a epi-endo approach, which basically takes out the left posterior wall. So you're really comparing PVI plus left posterior wall to PVI only. I would have preferred an approach that said you could do the same thing, endo and epi, and let's see what you get, but that's not what they chose. And consequently, and not unexpected, guess what? Doing the posterior wall plus the PVI, which is the convergent approach, did have a better long-term efficacy, 67.7% versus 50% in the PVI only. Both employed CTI, which is not routinely done by all labs unless people have a response, have flutter documented, but that was equal in both. The data on burden, in my opinion, is totally useless, if I have to be nice. I mean, the only way to really get burden is to have some implantable recorder in the patient or a pacemaker if they happen to have it. And this has been looked at multiple times, and people have looked at the burden as far as clinical occurrence and doing some occasional monitoring versus an implantable loop recorder, and they could be grossly different. So I would discount any of the so-called burden results of the study. And I think in the end run, I would agree with one of the author's conclusions, and that is that it appears in persistent atrial fibrillation that using a PVI plus posterior wall isolation may indeed be better than just PVI. And I think that's the message of the study. I don't think that authors have done what they should have done to prove that the convergent approach, epi-endo, is going to be better than an endo approach using the same technique. Thank you.
Good day, everyone. I am Musa Mansour, and I'll be presenting the results of the Precept trial on behalf of all my co-investigators. Here are our disclosures. While the safety and effectiveness of ablation of paroxysmal AFib is established, there are limited data on the outcome of patients with persistent AF. Moreover, no ablation catheter is currently approved by the FDA for persistent AF ablation. So the objective of Precept was to evaluate the safety and effectiveness of catheter ablation of persistent AF using a contact force sensing radiofrequency catheter. Here is the study design. It was a prospective, multi-center, non-randomized trial conducted at 27 centers in the United States and Canada. Patient had persistent symptomatic atrial fibrillation and were non-responders or intolerant to one or more class 1 or 3 antiarrhythmic drugs. The ablation was performed with the STSF catheter. The treatment approach was PVI or PVI plus ablation of additional targets at the discretion of the investigator. The study had a unique 15-month follow-up. The first 3 months was a medication adjustment period, followed by 3 months of therapy consolidation period and 9 months of evaluation period for a total of 15 months. Here are the primary endpoints. The primary safety endpoint was the incidence of primary adverse events occurring within 7 days of the initial and repeat ablation procedures. The primary effectiveness endpoint was the freedom from documented recurrence of atrial flutter, fibrillation, and atrial tachycardia of 30 seconds or longer, and freedom from any of the following failure modes at 15 months. And these failure modes were failure to isolate the pulmonary veins during the procedure, the use of a non-study catheter to isolate the pulmonary veins, more than 2 repeat ablation procedures during the first 6 months, recurrence of atrial fibrillation or AT or flutter anytime after 6 months, the use of a new or higher doses of antiarrhythmic medications that were not used prior to the procedure, repeat ablation anytime after 6 months, and surgical failure, which corresponds to surgical ablation anytime after the index procedure. Here are the patient's characteristics. I will keep it short. The effectiveness population was 333 patients, and the safety population 348 patients. Here are the results. This is a primary adverse event endpoint. Primary adverse event occurred in 3.8% of the patients. There were a total of 5 tamponade, 1 CVA, 1 TIA, 1 diaphragmatic paralysis, 1 pulmonary edema, 2 patients had pericarditis, and 3 had major vascular access complication or bleeding. So in total, 3.8%, and the primary safety endpoint was met. Here is the primary effectiveness endpoint, and this is the Kaplan-Meier curve at 15 months, showing a primary effectiveness of 61.7%, and the primary effectiveness endpoint was met. In addition to the protocol-defined success rate, we also looked at the clinical success rate, which was defined at freedom from documented symptomatic atrial fibrillation, flutter, and atrial tachycardia at 15-month follow-up, and that was 80.4%. This may be a useful success rate to talk to patients about rather than the 30 seconds recurrence rate, which may not be a good representation for clinical outcome in patients with persistent atrial fibrillation. In addition to safety and effectiveness, we looked at healthcare utilization, and there was a significant reduction in cardioversion use, significant reduction in use of antiarrhythmic drugs. Freedom from repeat ablation, shown in the top right panel, was 89% at 15 months, and freedom from cardiovascular hospitalization was 84%. Quality of life was significantly better and was measured using 2 quality of life questionnaires. So how does Precept AFib results compared to other clinical trials. So we looked at the results of 6 other clinical trials that are shown here. The one on the left used stringent criteria and are shown in blue. The one on the right used more lenient criteria and are shown in green. And if we use the protocol-defined success or a more lenient definition of success, the result of Precept were significantly better than all the other studies listed here. So, in conclusion, for the Precept study, persistent AF ablation using contact force sensing technologies is safe and effective. The primary adverse event occurred in 3.8% of the patients. Primary effectiveness was reached in 61% success rate at 15 months. The clinical success was 80.4% at 15 months. There was a significant improvement in quality of life. There was a significant reduction in healthcare utilization with 86% reduction in antiarrhythmic utilization, 86% freedom from repeat ablation, 75% reduction in cardioversion use, and 84% freedom from cardiovascular hospitalization. And thank you for your attention.
Last commentary is on the Precept trial, which, as you heard, was a prospective non-randomized trial of a contact force sensing radiofrequency catheter. There is an important clinical need for improved approaches to AF ablation in patients with persistent AFib and those with long-standing persistent atrial fibrillation. And one of the potential approaches is using a better catheter. I want to congratulate the Precept trial investigators on the successful completion of their study. The safety and efficacy profiles of the studied catheter are indeed encouraging. I really look forward to seeing the full results of this study. When I do, I'll be looking for the following: the number of patients with long-standing persistent atrial fibrillation. How does this catheter perform in patients with more remodeling, patients with more advanced structural heart disease? How were patients in their trial monitored for recurrent atrial arrhythmias? We know that the more you look, the more you find. How were these patients managed during follow-up? The investigators showed us some interesting data on the significant reduction in cardioversions and the use of antiarrhythmic drugs, but more granular data would be really interesting. What is the durability of the efficacy observed, and are the investigators planning to extend follow-up in their study? Will there be a cost-effectiveness analysis? I think this would be interesting, especially given the intriguing findings related to cardioversion and the use of antiarrhythmic drugs that they shared with us, and they can always use historical controls. It is important to keep in mind that procedures in this study were performed by experienced operators, and the results may not extrapolate to less experienced operators, and would be good to get more data on this catheter, perhaps in real world settings, and to see if these results can be replicated by other groups. Again, congratulations to the team, and thank you to HRS for inviting me to comment on these important trials.
I'm Eric Prystowsky, and I'm commenting on the hawk position, which is, you know, is the bird of prey. So a little eat your lunch type of a commentary on the Precept study by Dr. Mansour and colleagues. This was a non-randomized study, so it takes away from the power there. It basically was looking at one company's contact force catheter, the STSF. So the results really only pertain to these operators using this catheter, and they look to see the safety and the efficacy. And I think the safety I'm okay with. In the end, they had a 3.8% complication rate. I think that's within the typical accepted complication rates we see in these types of patients, so I don't have a problem there. As far as efficacy, honestly, maybe with the paper I'll have a better understanding, but when I tried to look through the efficacy as the authors showed their trial design, I thought I was once again in Paris going through the catacombs. I got lost in every little corner. I mean, there are so many different pieces to this that it's a bit dizzying. And I frankly am not sure what the results actually mean, because you could take antiarrhythmic drugs that as long as you didn't increase the dose and so forth, you could have 2 ablations. I really don't know in the end exactly what was done. And I think we have to wait till the actual paper comes out to take a closer look at the method. So I would say that I'm okay with the catheter and what the results were. I think it's reasonable. I'm not overly impressed, to be frank. And there are more recent data looking at cryoablation in patients with persistent AFib just with PVI, and they come up with pretty good results. So I think the true test of this catheter is to compare it to something else, and then we'll find out the efficacy. But as far as safety, I think the authors have shown me that it's fine, and I congratulate them on a difficult study, but I need a lot more data on their efficacy parts before I can comment.
Good morning, ladies and gentlemen. I'm Shizhan. Today, I would like to share you the topic: smartwatches significantly improve adherence to oral anticoagulation therapy among patients with atrial fibrillation. A multi-center, prospective, randomized control trial. As we all know that atrial fibrillation is the most common type of cardiac arrhythmia, and the AF prevalence of people over 80 years of age is about 10%. Patients with AF have 5 to 70 times elevated risk of ischemic stroke, which can be effectively prevalent by oral anticoagulation. The anticoagulant effect of oral anticoagulants will be greatly reduced 12 to 24 hours after medication. One or several missed doses may cause serious consequences. Therefore, it is essential to improve the drug adherence of oral anticoagulation therapy in patients with AF. However, adherence to therapy is the challenge for patients who receive this treatment. So, our objective is to evaluate the effect of a smartwatch that can send medication reminders on long-term OAC adherence in patients with AF. As shown in the picture is our smartwatch. In this multi-center, prospective, randomized control trial, 160 patients with AF who were prescribed long-term OAC therapy was randomly divided into 2 groups. The Moresky Medication Adherence Scale, a self-reported adherence measure, and the population of days covered, an objective measure, were used to evaluate adherence to OAC therapy. Adherence to treatment was defined as a score of 8 on MMAS-8, or as the PDC cutoff of equal or greater than 80%. Our 2 groups include the smartwatch reminder group and the standard care group. Both groups received regular follow-up calls and were scheduled for outpatient visits. In our smartwatch reminder group, OAC adherence were also ensured by a smartwatch with daily intake reminders, an intake error alarm, as well as an immediate telephone feedback function. after 9 months follow-up, the demographics, chest-wag scores, hospital scores, comorbidities, and combined medications was comparable between the two groups. And here we show the drug adherence measured by two methods. Here is the tendency of two groups. We can see that in the standard care group, the population of patients with an MASA score of 8 decreased from 66.3% in the first month to 40% in the 9th month. Similarly, the population of patients with PTC be equal or greater than 80% dropped it from 75% in the first month to 30% in the 9th month. In the smartwatch reminder group, the population of the patients with an MASA score of 8 increased from 62.5% in the first month to 77.8% in the 9th month. While the population of patients with PTC be equal or greater than 80% remained more than 90% all over the 9 months. So, in general, we can make the conclusion that a smartwatch that can send medication reminders can significantly improve adherence to OAC therapy in patients with AF. And thank you for your listening.
In this era of digital health, it is indeed interesting and intriguing to see the results of the smartwatch randomized clinical trial. I want to congratulate the investigators on the completion of this trial and commend them for doing a trial that addresses a problem of major public health significance. Adherence to and persistence of oral anticoagulant therapy in patients with atrial fibrillation beyond a year are abysmal, ranging from 25 to 50%. So there is an urgent need for interventions that could improve use and adherence to oral anticoagulants in patients with atrial fibrillation. Their trial is definitely intriguing, and it was clear that adherence was better in the smartwatch group. There was one important feature of their trial that I wanted to bring up, which is the fact that their patients had a relatively high CHA2DS2-VASc score. The mean was 3.4 in one of the arms, 3.7 in the other arm. But I was not able to appreciate the differences between the two measures of adherence that they used. I really look forward to seeing the publication of the results to be able to better understand those differences. I'm also eager to see if these results can be replicated by other groups, and more importantly, to really figure out if the effect of the smartwatch is durable, whether we can actually expect that effect to last for a longer period of time. Again, I want to congratulate the investigators on the completion of this trial, and thank you for the opportunity to comment.
I'm Eric Prystowsky, and my role here is to act as the hawk, which is the hawk position or the bird of prey position on commenting on the trial by Dr. Shi and colleagues on the smartwatches to increase adherence to anticoagulation therapy in patients with atrial fibrillation. Let me start off by saying that I am a huge proponent of anything that will be useful to improve anticoagulation adherence and reduction in stroke and AFib. So I congratulate the authors in taking on such a task. But in my position as hawk, I have to look a little more detail at some of the problems with this trial. So first of all, it's as best I understand it from what was presented to me, It is a so-called smartwatch, but not one that looks at an arrhythmia. It basically gives a signal to the patient to say you should take your medicine. So I think that's fine, but those sorts of things are available even now on many of the smartphones. I mean, there are ways to alert patients to medicine, but okay, that's still okay. And then they use this scale to judge this Mariski medication adherence scale. Frankly, I had to look it up. It's nothing I've ever used, but that's okay. It's apparently a useful technique here. And so what are the data? The data are a little disturbing to me, quite frankly, because if you look at the patients who are getting these notifications they should take their medicines, well, frankly, many of them were doing very poorly in the beginning, in my opinion. And then over time, they finally got better. So what's that all about? I would have thought that they should be right from the beginning, that group should be doing well. So I don't really understand that. It doesn't make much sense to me. Also, this PDC they're calling, which is greater than 80% daily adherence, I don't know how in the world you could figure that out. So here's my bottom line. My bottom line is I really congratulate any efforts to reduce stroke. I'm not sure this is the way to go. Frankly, I think if you had to do anything, it would be a smartwatch that had an arrhythmia detection in it, whether it be by actual electrograms or by plasmasmography or whatever technique, and actually could tell you have the arrhythmia. Not that that should mean you should or shouldn't anticoagulate, but that might be an extra impetus to tell them that. So I think there's a long way to go here. I'm a bit discouraged that there was such lack of adherence, even in the beginning with this watch. But again, this is like a first effort. I congratulate the authors for that. But at the moment, I think the data are still out on whether this is really going to reduce stroke risk.
Andrew Krahn, once again, closing this session. It's been an excellent opportunity to revisit the many realms within an electrophysiologist's practice with a focus on comparative studies. I think this has taught us a lot in terms of incremental management of our patients, new techniques, new technologies, and the utilization of a range of different additions to our practice that can improve care for our patients. I look forward to the discourse around the utilization of these data as they progress into our day-to-day lives. I'm grateful to both the presenters as well as the commentators, both the dove and the hawk, on providing insight into the merits of the data, its incremental value, and our use of it as we go forward. Thank you.